Hello everyone. Just one second. Yeah. So hello everyone. So welcome to today's session on the art of solving MCQs. So recently a grant test was conducted at DBMCI One. Hello everyone. Recently a grant test was conducted at DBMCI One, and I'll be discussing few MCQs, around 10 MCQs as far as that particular grant test was concerned. And what my goal with the help of this session is to make you understand, especially any NEET PG aspirant, that even if, let's say, you don't know the correct answer to a question, all right, even if you don't know the exact answer, and that is probably a question which you are seeing for the first time in your life, doesn't matter. You can still attempt that MCQ. You can still crack that MCQ. You can still crack that question. All right. Knowledge is going to help up till a point. You know, getting to a top 10,000 rank, I would say, or top 15,000 rank, that is knowledge game. You know, you go from a 1 lakh rank or 50,000 rank to a top 10,000 rank with the help of your knowledge. With increasing increment of knowledge, your knowledge keeps on improving and your rank keeps on improving. But beyond 10,000 and 5,000, the getting to the top 1,000 rank and getting to the top 100 rank and getting to the top 10, top 20 rank, I personally feel I never had I was not the guy who always had the most knowledge in the exam. But the reason I always got a top 20 rank in any entrance exam that I gave was because I knew how to solve MCQs. That even if my knowledge was not appropriate, or not appropriate is not the word, I had an adequate amount of knowledge, but I knew I was a better exam taker, I had more skills at solving MCQs, and I want to impart that knowledge with you guys. I want you guys also to understand how do you solve MCQs, what is the mindset of examiner, should be your mindset in order to get to the answer. Alright, so you have to understand that with the help of prior knowledge also you can solve some MCQs. Let's say you are stuck at 130, 140 correct, you can boost that to 150, 160 correct on exam day, giving you like a 20, 30,000 rank boost or 5, 10,000 rank boost simply on the exam day if you know how to solve MCQs. Grant tests are very important for these MCQs. They improve your exam taking ability. So regularly attempt GT. This is something which has been told by every topper and every person who has cracked this NEET PG exam. And MCQ solving is a skill, and every skill can be learnt. Every skill can be honed. So let's learn this skill today. Let's hone this skill today. So I'll begin. I'll begin with the first question that I'm going to discuss. A patient is diagnosed with a COVID-19 infection. All right. So the examiner is telling you a patient is diagnosed with COVID-19 infection and has a mild infection, and was started on this. Was started on what? Bamlanivimab and Atezolizumab. Okay. These drug combination act by which of the following mechanism? Okay, the options given to you are neuraminidase inhibition, RNA-dependent RNA polymerase inhibition, protease inhibition, blocking the spike protein. Now, if you see this question in the exam and you have never learned about these antibodies, you have never learned about these drugs, you will be like, I can't attempt this. Let me just skip this question. All right, you will be like, if I've never heard about these drugs, your mind would actually come to skipping this question. All right. But let me tell you, any exam, any question, think logically, think that can you attempt that question? Is there a way that you can, loop around and get to the correct answer? And in this particular question, there is a very easy way. Let's look at what are the drugs that they have given you. Let's say you don't have any prior knowledge. In fact, when I attempted this question, even I did not have any prior knowledge about these drugs, and I could still get to the correct answer. Let's see how I got there, and let's see how you can get there on the exam day. So they're giving you two drugs. They're giving you this Bamlanivimab and they're giving you Atezolizumab. The fact that they're giving you MAB towards the end, shows these are what? They are monoclonal antibodies. They are what? Monoclonal antibodies. They are monoclonal antibodies. Now think about any monoclonal antibody that you might have learned. You must have learned about rituximab. Rituximab is against what? It is against, and it's an anti-CD20 monoclonal antibody. It's an anti-CD20 monoclonal antibody. You must have learned about other monoclonal antibodies against different kind of CD receptors, like that, or different kind of proteins. But one thing that you have to understand about any monoclonal antibody, for that matter, you have to understand about any monoclonal antibody. If this is a cell, Can a monoclonal antibody enter the cell? It's a huge protein. Antibodies are huge protein. No. This is not possible. This thing is not possible. Monoclonal antibodies will always act on cell surface. They will always act on cell surface. So anti-CD20, for example, rituximab, if you assume this is rituximab, it will be acting where? It will be acting on the cell surface, and CD20 probably will be here. CD20 probably will be here. CD20 probably will be here. Any monoclonal antibody, if it's acting on cell, it's acting on the surface of the cell, which is having that CD marker or protein, so on and so forth. It cannot go inside the cell. It cannot go inside the cell. Now let's look at the options. The options were telling you it acts by inhibiting neuraminidase, RNA-dependent RNA polymerase, protease. All these are what? All these three things are what? They are enzymes. And they will be present where? They will be present inside the cell. They will be present where? They will be present inside the cell. Do you think a monoclonal antibody would be able to enter the cell and then inside the cell inhibit that enzyme? No. Drugs can do that, but a monoclonal antibody cannot do that. It's a protein. Protein cannot penetrate the cell membrane. Lipophilic drugs can. Protein cannot. So this inhibition, getting inside the cell, these three things won't be possible. The only thing a monoclonal antibody do is get on the cell surface. And what is there on the cell surface? You have that spike protein on cell surface. So if you have the SARS coronavirus, let's assume this is the SARS coronavirus, you will have this spike protein, and these monoclonal antibodies will attach to the spike protein and prevent these SARS coronavirus to enter other cells. Alright, preventing the propagation of the infection. But they cannot go inside the cell, and they cannot go inside the virus and inhibit these enzymes. They cannot inhibit enzymes like neuraminidase, protease, and polymerase. This is simple, basic, logical conclusion that you can come to. Alright, and this easily makes the answer correct. You can easily get to the correct answer. Even if you had no idea about what was bamlanivimab, what was etesevimab, if you had no idea about that, still you could get to the answer. The answer here would have been option D. Option D would have been the correct answer, blocking spike protein, and that's the correct answer. The correct answer to this question is option D, blocking spike protein. Alright, so simply by your knowledge that a monoclonal antibody cannot enter inside a cell and inhibit enzymes, it has to act on cell surface. And you get to the answer. All the other three options were enzymes. Alright, and that's how etesevimab and bamlanivimab actually act. These monoclonal antibodies, they will bind to the spike protein. They will do what? They will bind to the spike protein which is present on the SARS coronavirus, the COVID-19 virus, and they will not allow these viruses to enter inside the cells through the ACE2 through the ACE2 receptor. So this is how they act. So correct answer is 4, that is blocking the spike protein, and you can get to that answer simply by your knowledge of monoclonal antibodies. They had given you everything that you required in the question. They had given you MAB, they told you that these are monoclonal antibodies, and you could get to the answer. Alright, now let's move to the next question. A similar question. Nirsevimab is a monoclonal antibody with an extended half-life, which is currently being evaluated to protect infants against which of the following infection? Croup with severe stridor, epiglottitis, severe bronchiolitis, streptococcus pneumonia. Again, you might be like, if you encounter this question in the exam, you'll be like, what is this? I have never heard of this. I've never heard of this drug. Let me move forward. Let me not attempt this question. Again, no. Think logically, yaar. Think about what the examiner is trying to tell you. The examiner has given you everything. Even in this question, the examiner has given you everything. Even if you have no prior knowledge, you can attempt this question and get to the correct answer. Let's see. Let's see how. So they have given you 2 clues. What is the first clue that they have given you? They have given you the name of the drug. They have given you the name of the drugs. Nirsevimab. So it is what? It is a monoclonal antibody. It's a monoclonal antibody. And VI stands here for virus. In fact, in the last question also, both the monoclonal antibodies, if we go back to the last question also, this question also, bamlanivimab, etesevimab, whenever VMAB is there, VI-MAB is there, whenever VI is there in a monoclonal antibody, it's against a virus. You can get to that, right? Similarly, they are talking about a respiratory infection. They are talking about a respiratory infection in which age group? In infants in particular. Now, how do you get to the answer? So you must be knowing from your prior knowledge, we discuss this very frequently, it's a very frequently tested fact, must be knowing about what? You must be knowing about palivizumab. This palivizumab, this also has VI in it. This palivizumab, you must be knowing, is known to protect against RSV for bronchiolitis. It's a monoclonal antibody for protection against respiratory syncytial virus for bronchiolitis. And another thing that you know about bronchiolitis, is that bronchiolitis typically tends to occur in infants only. It typically tends to present at less than 1 year only. It typically tends to occur, this bronchiolitis is known to occur in less than 1 year on infants. This is the prior knowledge that you have. There is a drug called palivizumab given to prevent against RSV, which is known to prevent against what? Bronchiolitis occurring in infants less than 1 year. And this drug, this question is also giving you the same thing. It's giving you a drug with VI mab, so it has to be against what virus? Just like palivizumab. Just like palivizumab. Alright, and they are again telling you infants. So it must be which infection? It must be bronchiolitis. It must be what? It must be bronchiolitis. Even if you don't remember, bronchiolitis is common in infants. Even if you don't remember that, the simple fact that they have given you nirsevimab and VI is there means virus. Epiglottitis, you can rule out. It is caused by bacteria. It is caused by H. influenzae. It's caused by Streptococcus. You can rule this out. You can rule this also out. Streptococcus pneumoniae. Both are bacterial. You can rule that out. Croup, yes. Croup, laryngotracheal bronchitis. The most common organism is parainfluenza. It is parainfluenza. And severe bronchiolitis, again, most common organism is RSV. So even with this, you can get to 50% chance to get to the answer. And the rest, they have made it very amply clear. It is infants. In infants, what's more common? It's bronchiolitis more common. And you already have a monoclonal antibody called palivizumab. So from that prior knowledge also, you can make a good guess. And the answer here is that good guess only. The answer here is option C only, severe bronchiolitis. So this monoclonal antibody is against RSV only. It is against RSV only and helps in prevention against bronchiolitis. Helps in prevention against bronchiolitis. So this is how, even if you don't know the answer to the question, you can make a guess. You can get to the answer. Alright. So don't need to get worried about, oh, I don't know this question, or I have not seen this question ever in GTs or in previous year questions. Alright. Think logically, keep calm, and you'll get to the answer. Alright. And with this skill, there might be few questions you might miss. I'm not saying this is a 100% skill, all the guesses that you make will be correct. But even if you get 50 to 70% of your guesses correct, imagine the drastic improvement in your score. Right? Let's move on to the next question. A young man presents with difficulty breathing, exhaustion, and paleness after receiving what? After receiving penicillin. The lab tests now show penicillin antibodies and destruction of his own RBCs. He is diagnosed with immune hemolytic anemia. What type of hypersensitivity reaction is this? Type 1, type 2, type 3, type 4? What's the answer? What is the answer to this question? Can anyone tell me the answer to this question in the comment section? Can anyone tell me the answer? Can anyone tell me the answer to this question? So Anuj is absolutely right. This is a relatively simple question. The reason I kept this question in this discussion is that, we tend to think exam of something which is very, very tough. No. 50% of the MCQs in any exam are easy. Your rank is not going to be determined by the tough questions. There are going to be around 20 tough questions in any exam, but they are not going to determine your rank. It is your easy and moderate questions. If you get every single easy and moderate question correct, you are the topper. Not even top 10, you are the topper. Okay, no one gets a top 10 or a top 100 rank by solving tough questions. They get by ensuring that they don't make a mistake in an easy question and they don't make mistake in a moderate question. This is an easy to moderate question. It's a very simple question. They are saying what? That antibodies are being formed against penicillin and these antibodies are attacking the RBCs. What kind of hypersensitivity it is? What kind of hypersensitivity? So this is type 2 hypersensitivity. Everyone is absolutely correct. This is type 2 This is type 2 hypersensitivity. So a little bit about types of hypersensitivity reactions. So we know type 1 is what? These are allergic reactions. These are allergic reactions and IgE based. These are allergic reaction IgE based. For example, asthma. Example like diseases like, let's say, asthma. Or for example, I'm allergic to prawn. Giving you my own example, I'm allergic to prawn. So these are examples of type 1 hypersensitivity reaction. Type 2 is the one which we discussed. That these are antibody based. They are antibody based. That an antibody is formed that is reacting against something. These are antibodies based reactions. Type 3 is when there is immune complex formation. Type 3 is when there is what? Immune complex formation. So there is an antibody and there is a antigen and they have formed an immune complex. They have formed an immune complex, and this immune complex is the reason why you're having the disease. For example, particularly one very important example is post-streptococcal glomerulonephritis. Example like post-streptococcal glomerulonephritis. In post-streptococcal glomerulonephritis, what happens? You have an antibody which is formed against a streptococcal antigen. This antigen-antibody complex gets deposited where? It gets deposited in the kidney. And then this antigen-antibody complex activates complement, and that results in the glomerulonephritis. So when an immune complex is getting deposited somewhere, in rheumatoid arthritis, another example is rheumatoid arthritis. In rheumatoid arthritis, an antigen-antibody complex gets deposited where? In the synovium. So these, SLE, all these are examples of type 3 hypersensitivity reaction. Examples of type 2 hypersensitivity reaction, example of type 2. So here, it's a very clear-cut example. You have antibodies against RBCs, plain and simple. Type 2 hypersensitivity. The formation of those antibodies was stimulated by penicillin, but those antibodies, like I said, are against RBC. So this is simple type 2 hypersensitivity. This is simple type 2. Alright, this simple type 2 hypersensitivity. Type 3 is when immune complex formation is occurring. There is no immune complex formation occurring here. The antibodies are directly attacking the RBCs. If there was immune complex, that would have been 3. But here, are they giving an example of immune complex formation? No. They're saying that directly the antibodies are attaching to RBCs and destroying those RBCs, causing hemolytic anemia. Causing what? Hemolytic anemia. So examples of these diseases include autoimmune hemolytic anemia. It includes your myasthenia gravis. Right? And type 4 hypersensitivity is anything which is mediated by T cell. It is cell-based hypersensitivity. Example, celiac disease. For example, celiac disease, where the destruction is not done by antibodies. In fact, it is done by T cells. It is done by T cytotoxic cells. So celiac examples include a disease like celiac disease, where the destruction is not done by antibodies, done by T cells. Alright, so these are the different type of hypersensitivity reactions. So this is simple knowledge from microbiology, which they can ask in any of the subjects. They can ask it in pediatrics, they can ask it in medicine, they can ask it in microbiology and pathology itself. Which is the reason I always say that when you are preparing for the exam, instead of focusing on medicine too much, and this might offend a lot of medicine faculty, medicine is not the subject to focus on. In fact, pediatrics also, to take their offense a little bit down, pediatrics also is not that really an important subject. Path, pharma, micro. I repeat it for you guys. Path, pharma, micro. If you have a strong hold on these subjects, your medicine is done, your, pediatrics is done, your part of dermatology is also done, a part of your surgery also is done. Get a strong hold on path, pharma, and micro. Ensure that you ensure that you have good concepts as far as these subjects are concerned, and exam will be a smooth sailing. Now we move on to the next question. Let's discuss the next question. Someone has asked me, Manas has asked me, should I go in a defensive manner or should I go in an aggressive manner? I'll ask the GT solving doubts towards the end. A little bit of GT solving, a little bit of actual exam day strategy I'll discuss towards the end. Let's right now discuss MCQs. Let's see how you solve MCQs. And then towards the end, we'll discuss about the strategy part of it also, right? Question number 4. A 24-year female has committed suicide by drowning, and on postmortem examination, her lungs retain the same shape and do not collapse. Crepitus was heard, but little froth. What type of drowning it is? Freshwater drowning, seawater drowning, both A and B, dry drowning. Now, see, even if you, let's say, for example, have not revised forensic medicine in the last 7-10 days, but basic diffusion, basic osmosis, you remember. Even if you remember basic concepts from your 11th, 12th, 10th standard, now you can solve a lot of questions. I'll come to another question which you can solve with your 11th, 12th standard knowledge. This is also a question which you can actually solve with your 11th, 10th standard knowledge. I'll show you how. Okay, I'll show you how. So in freshwater versus seawater drowning. So in freshwater versus seawater drowning, what will happen? Let's assume these are the alveolus, for example. Let's assume these are the alveoli cells. These are the alveoli cells. In seawater, what will be there? There will be a lot of sodium chloride. Seawater is salty, right? So there will be water plus a lot of NaCl. There will be a lot of NaCl. Well, freshwater will be just water. So freshwater is going to be what? It's going to be hypotonic. Freshwater is going to be hypotonic, while seawater is going to be hypertonic. Well, seawater is going to be hypertonic. Now, in case of freshwater drowning, if there's a lot of water inside the lungs, which is hypotonic, what will happen? All this water will move inside the cell. It will move inside the cells. The cells will balloon up. Cells will increase in size in case of freshwater. In case of freshwater drowning, the cells will increase in size. Alright, they will balloon up. They will become emphysematous. If they become ballooned up, they will become this, the lungs will become what? The lungs will become bigger and emphysematous. They'll become emphysematous. And if there's a lot of water inside the cells, what will you hear? You will hear Krebs. So Krebs will be there. So you will hear what? You will hear a lot of Krebs. So crepitation will be there. So if you go back to the question, crepitus was heard. Crepitus was heard. Alright. And because all the water has come inside the cell, will there be any water left inside the lung? No. So what will happen to froth? There will be no froth. So Krebs will be there, but because all this water has entered inside the cell, because the water was hypotonic, the fresh water is hypotonic, froth will not be there. Froth will be absent. This is simple basic logic, hypotonicity and hypertonicity. In seawater, the water is hypertonic, so all the water will move out from cell. All the water will move out from cells, right? So cells will shrink, lungs will shrink, lungs will collapse, right? So cell size will decrease and lungs will what? They will collapse. And because now a lot of water will be there outside of cells, there will be a lot of frothing. There will be a lot of frothing. A lot of frothing will be there. A lot of frothing will be there. So this is how simple logic, yaar. Hypertonic and hypotonic. You can differentiate between freshwater and seawater drowning. All right. So this is a table which will be given in any standard textbook, in any notes. But simply think about it logically. In freshwater drowning, what will be the consistency? It will be emphysematous because cell size will increase. While in seawater drowning, because cells have been reduced of any form of all the water has been taken out from cell, they will become what? Jelly-like. They will become jelly-like. Shape after removal from body. In freshwater drowning, retain and it will not collapse. It will not collapse. While in seawater drowning, like I said, cell size will decrease. So it is not retained, it will tend to flatten out. It will tend to what? It will tend to collapse. It will tend to collapse. And on cut section, like I said, there will be what? There will be little froth in freshwater. There will be little froth because cells have absorbed all the water. While in seawater drowning, there will be copious froth. There will be what? There will be copious froth. As far as size and weight is concerned, in freshwater drowning, what will happen? In freshwater, if the cells have taken up all the water, what will happen to the density? Density decreases. Cells have taken up all the water, density decreases. The density decreases. So they will feel light. They will feel light. While in seawater, what will happen? Water has moved out of cells. So the density will increase. There is increased density in seawater drowning. So they will feel what? They will feel heavy. So this is forensic medicine. This is not my expertise. I'm a pediatrician. But everyone amongst us are MBBS students, and everyone amongst us has passed 11th and 12th standard and done physics there and done chemistry there and done a little bit of biology there. And simply from that particular logic, we can get to the answer. So they have given you, lungs retain the same shape and do not collapse. This itself tells you this is what? This is fresh water drowning. This is fresh water. Because in seawater, all the cells will lose all their water and they'll become collapsed, they will shrink. So this is going to be what? This is going to be freshwater drowning. This will be freshwater drowning. All right. Now coming to the next question. Which of the following adverse effect is often employed? Which of the following adverse is often employed as a therapeutic use for erythromycin? All right. Which of the following adverse effect is often employed as a therapeutic use of erythromycin? As far as erythromycin, think about the question again. Let's think about the question logically. Can you use QTC prolongation as a therapeutic use? Would you want to give someone arrhythmia? No. Can you use photosensitivity as a therapeutic use again? Would you want to give someone photosensitivity? No. Increase GI motility. Now this is correct. Especially for example, let's say there is post-operative ileus, constipation. Let's say there is post-op ileus. In that particular case, improving the GI motility can be a beneficial effect, can be a therapeutic effect, right? And this is how you're going to solve the MCQ. So as far as erythromycin is concerned, can there be any use of photosensitivity QTC prolongation? The answer is no. We don't want these things to occur in any individual for that matter. We don't want anyone to have arrhythmia. We don't want anyone to have photosensitivity. Increased GI motility can be used for post-op ileus. Can be used for what? Can be used for post-op ileus. And this is the reason erythromycin. We know that erythromycin stimulates what? It stimulates motilin receptors. It stimulates motilin. And this is what is going to get used as far as your erythromycin is concerned. So erythromycin can be given for post-op ileus. It can be given to improve GI motility. So correct answer here is going to be option B. It's going to be what? It's going to be option B. All right. Now we come to next question. Now, this is another important thing I wanted to tell you by. A lot of people, when they see a long question stem, what happens? When they see a long question stem, they will get scared. All right, they will think it's a very clinical question. Would they be able to solve it or not? Don't get scared. First rule, don't get scared. Keep calm. वो meme आती है ना आजकल, be a chill guy or a chill girl. The people who are chill during exam, they are the best exam takers. You have to be a chill guy. एकदम, है ना? Amir Khan used to say ना, ठंडा मतलब Coca-Cola. You should be that ठंडा during exam. All right. Now, let's see the question first. And another important skill as far as these long question stems is concerned, I will ask you guys to read the last line first. If you read the last line first, you understand what the examiner is trying to tell you when you go from the first line towards the end. Always read the last two lines or last line first. The last line here is saying these findings suggest a deficiency of which of the following vitamins. So this is a question which is going to be related to vitamin deficiency. That's it. This is a question which is going to be related to vitamin deficiency. Your mind is already tuned to that. A 68-year-old woman complains of chronic fatigue, anemia, right? Which has worsened over the past 1 month. She has experienced recent bouts of nausea and diarrhea. History indicates she changed her diet in order to lose some weight 3 months ago. When she started experiencing these symptoms, blood work reveals, they have already given you everything. Blood work reveals what? Blood work reveals macrocytic anemia. Vitamin deficiency, macrocytic anemia. Neurological examination is normal, is within normal limits. These findings suggest a deficiency of which of the following vitamins? They have given you such a huge question, Sam, but let me rephrase this question, what they are actually asking you. They are asking you, which of the following vitamin deficiency causes macrocytic anemia but no neurological changes? They're literally asking you this. They have given you a huge question stem, but they're asking which suddenly now the question feels very easy, right? Now you don't have a huge question to look at. It feels easy. Which vitamin deficiency causes macrocytic anemia but no neurological changes? These are the buzzwords. These are what are called. Neurological examination is within normal limits. These are what are called as buzzwords or buzz lines. They tell you the answer. So we all know macrocytic anemia. We all know what? This is very simple now. We all know macrocytic anemia is caused due to two deficiencies, either folic acid deficiency or vitamin B12 deficiency. It can either be folic acid deficiency, or vitamin B12 deficiency. But vitamin B12 deficiency also has what? It also has neurological changes. But here neurological changes are absent. So the answer has to be folic acid deficiency. Answer has to be what? Folic acid deficiency. Rest question really doesn't matter. Rest everything that they have given you. Chronic fatigue, recent bout of nausea, diarrhea, blah, 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 blue, something like that. All useless. The question starts from here. Blood work reveals macrocytic anemia, neurological examination, normal, which vitamin deficiency. That's it. Rest everything is distraction to waste your time. The correct answer is going to be option D. And this is the reason I'm telling you. They will give you a lot of questions which have a lot of distractions. Read the last line first. You'll get to the answer easily. The correct answer here is going to be folic acid. The correct answer is going to be option D. That is your folic acid. Alright, macrocytic anemia, neurological examination normal. If they would have given neurological examination as abnormal, then it would have been vitamin B12. Plain and simple. Right? Let's move on to the next question. All are true in SAM except. So some questions are little straightforward. Simple pediatrics, basic pediatrics. What is the definition of SAM? Okay. We define SAM as, we define severe acute malnutrition as if weight for length is less than -3 standard deviation, or any one of the following, or mid upper arm circumference is less than 11.5 centimeter, or there is presence of bipedal nutritional edema, or there is visible severe wasting. Okay. Now, you have to understand why the SAM criteria is this. Then the question actually becomes a lot easier. If you look at the first two criteria, you'll realize these are age independent parameters. Neither weight for length is age dependent, neither mid upper arm circumference is age dependent. Both are age independent parameters. Now, the concept of SAM actually came that the ASHA and the Anganwadi workers, they roam around in the villages, they roam around in the small towns, and they try to find these children with SAM so that they can nutritionally rehabilitate them. Now, a lot of time, these people who are belonging to this poor socioeconomic status, they won't remember the exact age of the child. Alright, in that particular scenario, in order to diagnose SAM or in order to diagnose acute malnutrition, you cannot rely on something which has age in it. So anything which has age in it was removed from the criteria. It was not considered important. Alright, that's why we use age independent measures like weight for length being less than -3 standard deviations or mid upper arm circumference being less than 11.5 centimeter. In both the cases, if you have weight for length, the ASHA and the Anganwadi workers, they can see the weight, they can check the weight, they can check the height. They don't need to know the exact age of the child. Mother might say the child was born 2 years ago, 3 years ago, they might say, then you actually probe them. Was he born near Diwali? Was he born near Eid? Things like that. But in a weight for length parameter automatically removes the need for knowing the age, and you can still diagnose severe acute malnutrition. So if the weight for length is less than -3 standard deviation, that is SAM. If the mid upper arm circumference is less than 11.5 centimeter, that is SAM. Presence of bipedal nutritional edema. Why was this added? This was to ensure that you always diagnose Kwashiorkor as SAM. See, in Kwashiorkor, because if you remember a little bit of Kwashiorkor, in Kwashiorkor what happens? The body is there's going to be loss of albumin in Kwashiorkor, and body is going to retain a lot of water. So what can happen if you retain a lot of water? Your weight can become falsely normal. And if you retain a lot of water here also, what will happen? The mid upper arm circumference can also be falsely normal. Right? This is the reason to ensure that a child with Kwashiorkor is severe form of protein energy malnutrition. This is the reason why this bipedal nutritional edema was added. That a child with Kwashiorkor is not said to be normal. He is considered as SAM. Similarly, this visible severe wasting was added to ensure marasmus is always considered as SAM. That marasmus is always considered as SAM. Alright, so let's look at the question. All are true in SAM except weight for age less than -3 standard. I told you the concept just now. You are not going to use age independent parameters. Option A is incorrect, except they are asking incorrect statement. Option A is the correct answer. So here the answer is going to be option A. Let's look at the other options also. We should always read all the options. A very common trick examiner uses, they give you the correct answer in option A and actually the answer is hiding in option C and D. So one another important MCQ solving skill is always read the 4 options even if you get to the correct answer in option A itself. Let's see the other answer options. Weight for height is less than -3 standard deviation. This is correct. Like I said, if the weight for length or weight for height is less than -3 standard deviation, that is SAM. That is how we diagnose SAM. Edema, like I said, yes. Bipedal nutritional edema, yes. Mid upper arm circumference less than 115 mm. This is basically nothing but 11.5 centimeter. This is a fancier way of saying 11.5 centimeter. So that is also correct. So correct answer here is option A. Weight for age is not used. Weight for age or height for age, these are not used in SAM. They are not used in SAM. Very important. And this was a recent INI-CT question. If I'm correct, this was the same INI-CT November question. Moving to the next question. Question number 8. Question number 8. While studying the structure of a small gene that was recently sequenced at the Human Genome Project, the investigator notices that the one strand of DNA molecule has 20 A's, 25 G's, 30 C's and 22 T's. How many base is found in the complete double-stranded molecule? This is class 12th biology. This is class 12th biology. And if you make a mistake in these kind of questions, you will not get a rank. These are the silly mistakes that you should avoid. That's why I kept this question here in discussion. And it's very easy to make a silly mistake. 20 A's, 25 G's. Okay, so 20 plus 25, 45. Option C, 45. Option C, automatically the mind is tuned to be 45. You mark option C. No. Keep calm. Let's get to the answer. Let's get to the answer. So what they are saying, there are 20 A's, 25 G's, 30 C's and 22 T's. What will be there in total? 20 A's, complementary DNA, A pairs with T. There will be 20 T. G pairs with C, cytosine. So there will be 25 cytosine. 30 C. So there will be 30 guanine. And 22 T means there will be 22 adenine in the complementary strand. The complementary strand. So what will be the total amount of adenine? 20 plus 22 is equal to 42. And where is it given? It's given in option A. It's given in option A. So correct answer is going to be option A. Calm. Very simple questions, but very easy to make mistakes in these questions also. Class 12th knowledge, complementary, base pairing, but still very easy to make the mistakes. Alright. Now, moving to the next question. A 48-year-old patient presents with fluctuating weakness, especially of proximal muscles. Alright. On examination, the DTRs are absent, but they become normal post-exercise. So this is what normal post-exercise weakness. Weakness which is becoming normal post-exercise. That is post-activity, the weakness is improving. This is what is called as the buzzwords. These are the buzzwords in the clinical questions that tell you the answer. Alright, so they are giving you history of weakness and improvement post activity. That's it. Alright. Diagnosis is myasthenia gravis, polymyalgia rheumatica, and they are giving another thing. DTRs are absent. So they are asking the diagnosis: myasthenia gravis, polymyalgia rheumatica, Lambert-Eaton myasthenia syndrome, or GBS. Now this question is a INI-CT favorite. This is another INI-CT favorite question. They've asked this question multiple times in multiple different formats. Same question, little bit wording here and there different, multiple times, like 10-20 times I can count. Probably they would have asked in the past 20 years. Okay. Now as far as GBS is concerned, you know, in Guillain-Barré syndrome there is ascending paralysis. Are they giving you any history of ascending paralysis? Fluctuating weakness becomes normal post-exercise. So you can easily remove this out. You can easily move this out. Then they are telling you DTRs are absent. Now, polymyalgia rheumatica does have weakness of proximal muscles. Yes, no doubt about that. But as far as polymyalgia rheumatica is concerned, you must know that it occurs in more than 50 years. Typically occurs in more than 50 years. Here they're giving you specifically 48 years. Alright, typically occurs in more than 50 years, typically associated with what? Giant cell arteritis. Typically associated with giant cell arteritis. Alright, and more importantly, it's a rheumatological disorder. So DTRs are going to be present. DTRs are going to be present. They're not going to be absent. Alright, so polymyalgia rheumatica is ruled out. Again, polymyalgia rheumatica is ruled out. So they're basically asking you whether this is myasthenia gravis or whether this is Lambert-Eaton myasthenic syndrome. And the simple difference that the answer is here. It becomes normal post-exercise. There is improvement post-activity. There is improvement post-activity. In myasthenia, if you remember from basic knowledge, that in the morning the patient is normal, by the evening the drooping of the eyelids starts, the weakness worsens. With activity in myasthenia, the weakness worsens. While in case of Lambert-Eaton myasthenic syndrome, more the activity that you do, the weakness improves. So correct answer is going to be option, is going to be what? It's going to be option C, Lambert-Eaton myasthenic syndrome. So a little bit about neuromuscular transmission. So let's say the signal is coming from the nerve. This signal does what? It does. It causes calcium to move inside. This calcium causes what? It causes the vesicles. It causes the vesicles to fuse with the membrane of the nerve cell at synapse. This is the synapse. And these synaptic vesicles are then going to release what? They are going to release your acetylcholine, which is then going to bind to the receptors, the nicotinic receptors. Alright, it's going to then bind to the neuromuscular receptors. In case of myasthenia, if you have more and more activity, what is going to happen? If you have more and more activity, this acetylcholine, what will happen to this? It will get depleted. It will get what? It will get depleted. It will get what? Depleted. Alright, it will get depleted. This acetylcholine will get depleted. In myasthenia gravis, what is happening? What is the main pathophysiology in myasthenia? There are antibodies against NM, neuromuscular. So there are antibodies here. There are antibodies here. Alright, if you have more acetylcholine, those acetylcholine can displace those antibodies. It's a competitive type of inhibition. It's a competitive type of inhibition. Those acetylcholine can displace these antibodies. But if you have repeated stimulation, if you have more and more exercise, if you do more and more activity, this acetylcholine will get depleted. And then it won't be able to displace these antibodies and the neuromuscular transmission will suffer and you will have increase in weakness. So this is what happens in myasthenia gravis. As far as Lambert-Eaton myasthenia syndrome is concerned, as far as LEMS is concerned, there's a problem here. The calcium is not able to get inside the cell. If you have more activity, what will happen? More signals will reach, more signals will give more signal for more calcium to come inside. So that's why with the activity, more calcium is able to get inside and more synaptic vesicles are getting released. That's why in case of myasthenia gravis, there is worsening, while in LEMS, there is improvement post activity. Alright, so these are the clinical questions that they will ask, but they have given you a very simple scenario. Becomes normal post exercise. The weakness becomes normal. Weakness becomes normal post exercise. Immediately think of LEMS. Immediately think of LEMS. Alright. Coming to the last question, coming to the very last question of this discussion. A 26-year-old first gravida at 28 plus 4 weeks presents with contractions and cervix dilated. So this is what? This is preterm labor. This is what? This is preterm labor. What is the correct dose of MgSO4 for fetal neuroprotection? Then they're giving you 4 options. Okay, they're giving you 4 options. The last option obviously is not the correct answer. No need for magnesium sulfate. You need magnesium sulfate. This is a preterm baby. Magnesium sulfate will do what? It will do fetal neuroprotection. It will do what? It will do fetal neuroprotection. Magnesium helps in, MgSO4 helps in fetal neuroprotection. And MgSO4 is given to anyone whenever there is a preterm labor less than 32 weeks. Less than 32 weeks. Now the question comes, how do you decide between these 3 options? Even if you remember eclampsia, even if you remember preeclampsia, then you will be able to solve this question. Even if you remember preeclampsia, you will be able to solve. If you remember the magnesium, how it's given as far as preeclampsia is also concerned, you will be able to solve this question. Similar only, nothing much different. All right. As if you go back to preeclampsia, there are two regimens which are very important regimens, very important regimens. We all do it for preeclampsia. There's the Pritchard regimen, there's the Zussman regimen. In the Pritchard regimen, we give as far as bolus is concerned, we first the initial bolus and the loading dose is concerned, initial loading part is concerned. What do? We give a 4 gram IV, 20% of MgSO4, 20% MgSO4, 4 gram IV, followed by 5 gram intramuscular in both the buttocks, one buttock. So total we give what? We give 14 gram. This is a Pritchard regimen. And then we keep on giving 5 gram every 4 hourly. Then we keep on giving 5 gram every 4 hourly. This is very important from AIIMS, very important from INICT. Multiple times they have asked the Pritchard and Zussman regimen. Zussman regimen says that we have to give 4 to 6 gram IV, over 15 minutes, 15 to 20 minutes. MgSO4 is never given in 1 to 2 minutes. Always remember that. I'll come to the reason why. Why is the MgSO4 not given over just like a bolus? It's never given over like a bolus. It's always given over 15 to 20 minutes. Ideally should be given very slowly, 15 to 20 minutes. Followed by 1 gram per hour for 24 hours or till labor. Alright, with this knowledge, let's come to the question. Alright, a 6 gram bolus over 5 minutes. Wrong. A 4 gram bolus over 5 minutes, again wrong. A 4 gram bolus over 15 minutes. This is correct. Option C is the correct answer. For fetal neuroprotection, anyways, for fetal neuroprotection, we don't prefer to give 6 gram, we prefer to give 4 gram. The correct answer here is going to be option C. So even if you don't remember fetal neuroprotection and MgSO4 dose, you can use the prior knowledge of Zussman or the Pritchard regimen and come to the answer. Pritchard regimen is not applicable here, it's anyways not applicable here. But the Zussman regimen always says 4 to 6 gram over 15 minutes. Right? Over 15 minutes is the important part. We never give it over 3 to 4 minutes or for 5 minutes. So option A and option B are immediately ruled out. Alright. Remember that MgSO4 is always given over 15 to 20 minutes. We never give it very fast. And now I'll come to the reason why we never give it very fast. Why is it not given very fast? And I'll tell you a personal story. Another important use of MgSO4 is asthma in status asthmaticus. We had a 7 or 8-year-old female child and she came to us in casualty. This is a personal story. So I remember that the SR, I was a junior resident at that point of time. The SR, she had severe status asthmaticus, was not responding to, your corticosteroid, salbutamol, so on and so forth. So he decided that he has to give MgSO4. So he wrote injection MgSO4, whatever the dose, IV. He just wrote that. The nursing officer unfortunately did not know this concept that the MgSO4 cannot be given over a bolus. It has to be given slowly. That nursing officer unfortunately gave the and it was a slight mistake on the part of the SR also, I would say, that he should have written over so and so time. Alright. So nursing officer unfortunately gave it bolus, but it's very common knowledge, MgSO4 not a bolus. No. If you give MgSO4 suddenly and thus a magnesium level suddenly rise, magnesium inhibits calcium. That's the main thing, right? Instead of calcium going inside the cells, helping in neuromuscular transmission, helping in cardiac conduction, magnesium comes, it doesn't help, it doesn't allow calcium to do its function. The child underwent, unfortunately, a cardiac arrest. She came with asthma and unfortunately we gave her a cardiac arrest. Luckily she was revived and by God's grace, nothing untoward happened. There was no neural deficit also. But I still remember that very clearly, right? Like a child comes with asthma. Asthma is like a normal occurrence in emergency. And suddenly the child is having cardiac arrest. You are like, what the hell happened? And now you got to know that MgSO4 was given over bolus. So in this, remember always in Zussman, it's not 3 to 4 minutes. It's always 15 to 20 minutes. It's always 15 to 20 minutes. Never give it like over 1 to 2 minutes. Something which you can remember when you become residents also. All right. So this is a personal story. Now, MgSO4, what does it cause? MgSO4, side effects of MgSO4 are again very frequently asked. So first sign is loss of deep tendon reflexes. Then it can cause respiratory depression, and it can cause cardiac arrest as well. And everything, like I said, why? Basically, magnesium will not allow calcium to work. So no calcium, loss of DTRs. It won't allow nervous conduction to occur properly. Then the diaphragm won't be able to contract properly. So respiratory depression, and then finally a cardiac arrest can also occur. All right. So here, even if you did not know the actual dose for neuroprotection, if you did not know the dose, simply by going back from your Pritchard regimen and Zussman regimen knowledge, you can come to the conclusion that option C would have been the correct answer. Option C would have been the correct answer. All right. So the dose for the MGSO4 dose for neuroprotection, we give 4 gram, most importantly, over 15 to 20 minutes, followed by 1 gram per hour. Followed by 1 gram per hour. Followed by 1 gram per hour. All right. So this is the answer. This is the answer. All right. With this, I take your leave. With this, I will take your leave. I'll answer a little bit of more questions related to GT solving. First important thing, I want to keep you guys attempt all GTs. GTs are not the real exam, but that's the entire point. They are not the real exam. So that all the mistakes that you do during GTs, you don't make the same mistakes during exams. Very important. All right. Make all the mistakes during GT so that actual exam is a cakewalk. So that actual exam is the cakewalk. Someone has asked me, I get confused between two options and end up choosing the wrong answer. While the second option I thought was correct. How to know the gut feeling was right while solving MCQs? Go with the first gut feeling. Go for the first gut feeling. You're having that gut feeling because somewhere in your memory that information is stored. So go for the first gut feeling. That's very important. Second, this particular problem, this shows what? A lack of revision. This shows a lack of last 7-day revision. You know why I keep on emphasizing on this last 7-day revision? See, you would have done the syllabus once, you probably will do it twice, revise it another time. But if you don't do that last 7-day revision, you will get confused between two options. If you have done the last 7-day revision, all the information would have come in front of your eyes in the past 72 to last 100 hours. So you will not get confused between two options. That is why there is so much importance to that last 7-day revision. And overall, if I'll say, it's not that you can still get confused, not like you can't get confused. Go for the first gut feeling. All right. Give as many MCQs and give as many grand tests as possible. That will improve your MCQ solving ability. All right. You will be able to attempt MCQs better. You will be able to, rule out options better. Always read the 4 options. And a lot of people tend to lose calm in the exam. And I'll simply say to them, there are 2 methods that you can do. A little bit of personal story also, so that might help you guys. First is always the very simple. Stop doing any questions. Like for 2-3 minutes, stop doing any questions. Don't move to the next question. Stop doing any questions. You're anyways in a very panicked mood. And whenever you have a sympathetic overactivity, you won't be able to solve the MCQs. That's a known fact. Relax. Keep calm. First of all. Now you'll be like, sir, bolna bahut aasan hai. It's very easy to say it. How do we actually implement it? So what I used to do was simple breathing exercises. The Anum Vilom and Pranayam. If any time I felt that, 3-4 MCQs have gone bad, what happens for a lot of people, panic sets in. That 3-4 MCQs have gone bad, I won't know the answers to the rest of the MCQs. Stop all the MCQs. Keep calm. Look at the surroundings. Close your eyes. Breathe in and breathe out. For next 2 minutes. Nothing is going to happen. You are not going to lose out on any MCQs. Breathe in, breathe out. Get your nerves to calm down and then again start attempting the MCQs. Start with a fresh mind. There's no harm in doing that Anum Vilom and Pranayam for next 1 to 2 minutes. It's going to be very helpful. Anytime in the exam you start to panic. Very important. Now coming to the personal story. So first exam which I gave, first competitive exam I gave was 2012 AIPMT prelims. And from those who remember from PMT days, what's the first section that you attempt? Just always your biology. And the very first question, imagine you are a 17-year-old child, the very first competitive exam that you're going to give in the life. The very first question that you see It was not from NCRT. It was not from NCRT. I panicked. I was like, all my preparation is down the drain. I had bet so much on doing only NCRT. And now the very first question is not from NCRT. How will I solve this? How rest of the questions will also from NCRT. My whole entire bio is, my entire 2 years are wasted. I panicked. The exam started at 10 a.m. I kept on panicking for 5 minutes, till 5 minutes. Then I calmed my nerves down. And then I did this breathing exercise. Finally, I did this breathing exercise. Someone had told me and I did that. For those who believe in God, I used Gayatri mantra. You can have your own set of mantras and everything depending upon what you follow. I did the breathing exercises for next 5 to 10 minutes, and 10:15 I started again from the second question onwards. And guess what? The rest 99 bio questions, all from NCRT, I got all of them correct. So don't let that one small setback, bother you. A 1 GT doesn't go well, fair enough. Next will go well, fair enough. Another will go well. The good thing and the bad thing about medicine is same. The fact that it's so long also means that you will get multiple opportunities to redeem yourself. Right? So don't be scared of GTs, attempt all GTs. And I'll be coming with this session again and again. We'll be discussing these MCQs together. We'll be discussing some concepts together, and we'll get to the answers, and we'll solve and get the best rank possible that we have in the actual exam, NEET PG, likely to be conducted in June 2025. Right? Thank you. Thank you so much. It was a pleasurable session. All right. It was a pleasurable session. Yes, another person asked, defensive or aggressive? So two things. Depends upon how many corrects you are having. Beyond 130 corrects, always aggressive. Beyond 130 corrects. Beyond 130, I will go a little low as 125 corrects also. If you have reached 130 corrects, always aggressive. Less than 115, I would say, defensive. If your corrects are less than 115, defensive. 115 to 130 is a transition zone. Basically, like I said, knowledge, what will help with knowledge? Knowledge will help you get to 130, 150 MCQs. And after that, it's a game of MCQ solving. It's a game of aggressiveness. All right. So beyond 130, always be more aggressive in the number of attempts that you're giving. Less than 130, less than 110, definitely be more defensive. Between 115 to 130 is a mix and match game. It's a mix and match game. At that point, that shows if you're getting to 120 correct, it means a little bit of knowledge is still lacking. Maybe in some important subjects. 5 main important subjects, I'm again telling you: Path, Pharma, Micro, Surgery, Obs, Gynae. Not saying medicine. Path, Pharma, Micro, Medicine and Surgery. Surgery and Obs, Gynae. If you're lacking somewhere in these subjects, you might not be able to get to the you need to improve your knowledge, especially on these 4 subjects is concerned. You need to improve your knowledge. All right. For FMG, I'll be conducting another session tomorrow. Tomorrow, I'll be having another session specifically for FMG, Paediatrics related to FMG. And can you crack the exam in 1 month? That depends on your prior knowledge. We'll discuss these questions later tomorrow. Thank you for the today's session. I really enjoyed it. I hope you guys enjoyed it. And I hope you guys give up constructive feedback on what I can improve. All right. Thank you and have a nice day.